Welcome, everyone, and thank you so much for attending this webinar on mental health crisis programs in California, our formative evaluation. I'm Melissa Martin Millard. I'm the Chief of Research and Evaluation with the Mental Health Services Oversight and Accountability Commission, usually just shortened to the Mental Health Commission for obvious reasons. And I'm just going to go over a couple of housekeeping items. We will make these slides available to you after the webinar is completed. Yeah, everyone should be muted. So if you do have questions or comments, the chat is open. So we just ask that you type questions there. And then at the end of our presentations, we will have time to address those questions. Let's see, what else? I think we can go to the next slide. And then the last housekeeping item is at the end of the webinar, there will be an opportunity to provide feedback on the formative evaluation. There'll be a link for you to use to ask any further questions or just provide feedback in general. So please make sure to do that as well. All right, so I'm just going to give a tiny bit of context about the commission in general for anyone who's not familiar, but just to spend a minute or two on the commission before I turn it over to our research partners from UCLA and UC Davis. So the commission was formed through the Mental Health Services Act legislation about 20 years ago, and it really provided additional funds and some structures, including the commission itself, to help support and supplement the public behavioral health system. So today, the Mental Health Services Act funds are about a quarter of the entire public mental health system. So obviously through this unique funding source, it creates some wonderful, innovative opportunities for grants, for evaluations, for really thinking about the levers we can use to transform the public mental health system. Next slide, please. The commission is in its very last year. So at this point, we're in our last few months of the strategic plan that we developed in 2020 through 2023. The plan had 3 overarching goals with 3 objectives that are nested under each of those goals. And this evaluation and the triage / SB 82 project overall really provides has a connection to each of our strategic goals. We really want to help provide a vision for mental health in California. We want to leverage and use data and evaluation to help tell our story. And we also want to engage the community in this process. So hopefully today, as our research teams kind of walk through the findings and the process that they went through to gather this information, hopefully these 3 goals are reflected in that. And I think that they will be, that you'll find that they are. And then lastly, kind of the other way that we think about our work at the commission is these levers for transformational change. And every single one of these levers was a part of the SB 82 project, from the grant dissemination to some of the technical assistance to the evaluation piece. So we are using today this webinar as kind of a communications piece and a community engagement component. But again, all of these levers are reflected in this triage project overall. So today what we're going to do, I think we can go to the next slide. Today what we're going to do is to, kind of use this as an opportunity to solicit feedback and public comment on the evaluation before we release the final report. We're going to start with our research team from UCLA. They provided the formative evaluation on the child and school county collaborative programs. Then we'll move into the UC Davis team, who conducted the formative evaluation on the adult and TAY programs, transitional age youth programs. So with that, I'm going to turn it over to Dr. Corey O'Malley, who is a postdoc at UC Davis and the lead on the work of UCLA. So with that, Dr. O'Malley, I turn it over to you.
Hi, thanks, Melissa. Appreciate that introduction. So just to clarify, I'm the lead qualitative researcher on the UCLA team, which is a broad group of people that have all contributed enormously to this multi-year project led by principal investigator Dr. Bonnie Zima. So I do want to acknowledge our entire team before I start talking to you guys a little bit about this formative evaluation of the SB 82-833 programs. So as Melissa very helpfully pointed out, the origins of this program are in the Mental Health Services Act passed in 2004, and then in the legislature passed SBs 82 and 833 to really create a distinct set of crisis triage grants. And these are specifically personnel grants that are administered by the MHSOAC, so the commission. And we're looking right now at round 2 of this grant program, which was awarded in 2018. And on the child and the school county side, this included 11 grantees for child youth crisis triage programs and 4 school county collaborative programs. Now, I'm going to use the word program throughout this presentation, but because these are personnel grants, what we're really looking at is a set of programs, some of which were created from scratch using these grant funds. In some cases, programs that used crisis triage personnel in units that already existed. But whenever I say programs, I'm really referring to the programs that received these crisis triage personnel and the ways that they used them to achieve the types of goals that Melissa introduced in talking about the MHSOAC's goals. So to just give an overview of the grant recipients, they really span the entire sort of gamut of the state of California. So 2 of the programs are in the far northern Superior region of California, 7 in the central region, 1 in the Bay Area, and then 5 in Southern California. So you can see very different contexts that these crisis triage personnel are being used in. The actual composition of the counties also vary. As you can see here, a little over half of the counties that received funds are large metro counties. A little over a quarter are medium metro, meaning they do have large cities, but there may also be some smaller cities, some more rural and isolated areas. And then 3 programs receiving funds are in counties that are really rural, in that they are largely isolated communities and have really specific needs. And then in terms of the types of programs that received funding, we kind of grouped them broadly into 2 kind of sets. There was a set of 9 programs that we were considering county-based. They were largely delivering services in and through county offices, as opposed to another 40% of the programs, which were primarily school-based. And so with those school-based programs, that of course includes the 4 school county collaborative programs, as well as 2 child youth programs that primarily delivered services in schools. So then that leads to the next question of, well, what does youth crisis triage do? Crisis triage is a very broad set of interventions that are designed to link clients, families, to the resources that they need to support their mental health and wellness. So crisis triage really occurs across the entire crisis care continuum, ranging from prevention, early intervention, acute crisis services, treatment, referral, care coordination, and even community outreach. So I've given some figures here to just see of the awarded programs, what percentage of each of them really are identified each of these areas as a major primary target for them. So you can see for most of these targets, more than half or so of the programs are trying to address them. And what's not visible here is that in a lot of cases, these programs were trying to do multiple different types of services at once. This was especially the case for school-based programs. So for us as an evaluation team coming forward, we needed to look at these very broad set of programs and try to make some sense, try to tell some statewide story of what's happening with their implementation. So what we really tried to do is describe and assess the activities, the processes, the outcomes that we saw in real time as these programs were carried out. And then doing that to identify some barriers and facilitators, things that made it easier to deliver these programs, things that were durable challenges to these programs, and then ultimately to be able to provide some lessons learned, evidence-based recommendations for future program implementation. Now, to do that, we used a community partnered mixed methods approach. Our community partnering took place through a lot of activities, but main ones included work groups with individuals involved in implementing the programs. So we met regularly with folks who were delivering these services to understand the challenges they were facing in real time. We have an advisory board that helped us better understand what types of themes we should address further and which types of things we needed more context for. And of course, we've also incorporated public feedback throughout the process. Then in terms of the data sources that we used, we really primarily used qualitative interviews as our main source of data. So we talked to program leads and personnel, and we also surveyed them to understand some of the activities that these programs were engaged in and some of their impressions of the types of impacts those programs might be having. And then we also collected data through our regular engagement activities. By working closely with these programs over time, we were able to just collect all sorts of bits and pieces that helped us put together a good, rich, deep understanding of the challenges that they faced. And I do just want to briefly kind of give an overview of how we conducted those interviews as well. So we did talk to these leads and staff at these programs basically every 6 months for the period of time that these programs were in operation. So for most of them, that was between 2019 and 2022. As you can see here, the first 2 rounds of interviews occurred prior to the start of the COVID-19 pandemic. So we were able for most programs to get some sense of baseline and early development of those programs prior to all of the adjustments that of course had to occur due to the pandemic. But what you can see here is that we really checked in regularly and we had a variety of different types of participants so that we could kind of cross-check what we learned, develop themes, and then learn from other individuals with other types of roles how they approached, viewed, or handled some of those challenges. And then you can see from the number of interviews that there was some attrition, there was a little bit of change over time. Not all programs lasted the entire program, the standard program length. And we did have to use a modified schedule for one county that ran from 2020 to 2023. But that leads me to our findings. So we're really trying to tell here the kind of statewide story of these SB 82, 833 child, youth, and school county programs. And to do that, I'm going to kind of walk through these 5 points and then sort of expand on them to illustrate how they affected program implementation. So the first point is that these programs really represented a really big variety of different approaches to crisis triage. Each of them was really tailored to fill specific gaps in their local service systems and address very particular community needs. Somewhat unsurprisingly, this meant that these programs sought to address a lot of the same problems that they faced involving the delivery of community mental health services. So they were designed to fill particular gaps. Indeed, they also, in a lot of cases, suffered from or needed to work through exactly those gaps in order to do their work. And so as a result, big facilitators of these programs were their adaptability, their capacity to engage in organizational partnerships, and the extent of leadership engagement at basically every level of the program, from the on-the-ground leadership to leadership at the counties to leadership at the partnering organizations. And we also found that successful programs depended very heavily on experienced and dedicated personnel to overcome what were very pervasive, in some cases, workforce challenges and limited and sometimes constrained organizational resources. And then lastly, we found that the programs faced significant barriers relating to their sustainability, including challenges in identifying sources of funding and revenue, as well as in data collection and reporting, which are, of course, important components for programs in securing future funding or identifying sources of revenue. So I'm going to go through each of these to kind of outline why these mattered to the program. So first of all, the first finding has to do with the kind of variety of things that the programs are doing. So I said before, they vary widely in the kinds of communities they serve. They also varied in the settings that they were actually operating in. I said before that 6 programs were operating in schools. We had 4 that were based more or less in some sort of a mental health county office, 2 programs that were primarily field-based or mobile. They did not have a main home base, and then 1 program each in an emergency department or a police department. So again, you can see they're doing very different things. They are managing very different types of environments and delivering these services. And likewise, this is a repeat of the slide you saw before. They're doing very different types of services, right? Some of these prevention, early intervention, community outreach things are going on at the level of a universal intervention in schools, whereas other programs are really focused on providing acute services in response to immediate crises, right? So we see across the gamut a very wide range of services that these programs are providing in a very wide set of settings. And beyond that, they vary a lot in their complexity. So when we looked at the actual structure of the programs, looked at how they were organized, how they were ran, they involved partnerships across different agencies and sectors. In some cases, they involved multiple teams or units that were operating in different settings or even entirely different regions. And in a lot of cases, they were navigating multiple regulatory systems, especially for school-based programs that need to manage both the regulatory systems within schools as well as within the mental health and health services field. This is also the case in emergency departments, police departments, anywhere where there's an additional regulatory burden or compliance burden that gets placed on the programs. However, we also found that the variation in the programs, that complexity, it's largely due to the fact that they are so tailored to the communities. So rather than being something where these are kind of unnecessarily complex, or that these are particularly in a way that is not coherent. In fact, we found that in most cases, there were very good reasons why the programs were designed the way they were. So we found that this variation, this complexity was sort of necessary and advantageous. It allowed these programs to fill very specific niches, but it also created challenges for them because in many cases, they had a large degree of either regulatory, administrative, or organizational burden on top of just delivering the services that they set out to deliver. And this relates to the second point, having to do with the challenges to program implementation, because the programs were often faced with many of the same challenges that they were intended to address. So there is an identified structural or systemic inequality in a community, and so the program is both designed to fill that, but is also facing the existing external aspects of that challenge that are not in their control. And this is likewise true of limitations in community assets, of provider shortages in communities, and indeed the COVID-19 pandemic itself. We found again and again that programs worked very hard to discreetly overcome the exact types of systemic challenges that they were intended to help address. And while this is important, it is of course the case that they're not necessarily going to be able to overcome them independently of other forces. So these factors were identified as barriers to program implementation and reach by programs, especially those in rural, isolated, and more historically underserved communities. So there was definitely a difference between programs that were dealing with more entrenched systemic community issues versus those that were not. But we found that despite that, the 3 biggest factors that sort of predicted, for lack of a better word, program success were adaptability, organizational partnerships, and leadership engagement. Now, this may be a little bit of a statement of the obvious or look like a statement of the obvious, but what it really came down to is of the dozens of different factors that we looked at in understanding why certain programs were able to more or less carry out the programs they intended to. The successful ones were the ones that were most able to adapt. They believed they had sufficient capacity, they believed they had the authority, and they were willing to be flexible in their approach to challenges in real time. If programs had that level of adaptability, it tended to depend on things like organizational partnerships. So organizational partnerships made that adaptation more possible. And conversely, where organizational partnerships did not already exist, personnel worked a lot harder to overcome sometimes even basic hurdles. And then leadership engagement was critical to those partnerships because the partnerships themselves were strengthened by leadership engagement on the part of partners at all levels. Factors that supported this included examples of co-location or institutional embeddedness. So when you have the organization and the leadership all housed within the same location, as well as formal partnerships that facilitated regular information sharing, bypassed bureaucratic or policy barriers, and established routine, reliable communication channels. Where those things didn't exist, there were a lot more challenges with implementing programs, especially during the pandemic. And indeed, successful programs also depended very heavily on their experienced and dedicated personnel to overcome workforce challenges and limits in their organizational resources. Again, it may sound like a statement of the obvious. You want to depend on the experienced and dedicated personnel, but we found that hiring and retention was such a challenge for some of these programs that there was an enormous burden that was placed on existing personnel. And in some cases, that turnover really limited the development of institutional knowledge and networks. We also found that there were a lot of contributors to staff turnover, including the stresses related to the nature of crisis work, prevailing public sector compensation, and work conditions, especially during the pandemic. And indeed, hiring was particularly challenging for certain types of programs, especially those who had short-term positions, positions in areas that had extensive provider shortages, or hiring for positions that had extensive background or licensure requirements. But despite those challenges, there was generally a positive attitude about program quality, except for there was a great deal of need for additional support around administrative functions, data support, and as a result, programs tended to rely heavily on personnel that were willing to go beyond the scope of their responsibilities, including in a lot of cases, individuals that were not funded by the grant. Our final finding has to do with the barriers to sustainability. So these pilot programs really did face significant barriers in identifying sources of funding and revenue to sustain their operations. In part, this is a program that funded personnel only. So the programs had to kind of patchwork together additional sources of funding and revenue to support both their ongoing operations as well as their operations after the program ended. And they did that through a variety of sources ranging from Medi-Cal, other MHSA funds, county community funds, other grants, but they generally had an extremely difficult time securing adequate, predictable, long sources of funding, especially for programs that were doing work in prevention, early intervention, universal supports, or supports in schools. So I'm going to also link to that this challenge of data collection and reporting. So we talked at enormous length to program staff about data collection, since that was also part of what we did. But we really found that access to resources, the differences in the quality and of county and data infrastructure, organizational and regulatory challenges, and of course, complications from the pandemic made it extremely difficult in a lot of cases for counties to identify the types of data sources that were available to them and not have those obligations basically take away from the service components. So indeed, we had a number of programs identify the non-service, so the not direct clinical care components of their program to be the most difficult to implement. In some cases, actually requiring licensed staff to take time off of their clinical duties to address administrative and data collection duties. So this brings us to some key lessons. First of all, I do want to say crisis triage shows enormous promise for filling major gaps in the mental health system. It is viewed by counties as a wonderful opportunity to introduce more services, increase access to populations that have been underserved. And the complexity of these programs is a reflection of how important they are. So the fact that these programs are filling all sorts of gaps really reflects how needed they are. However, they may need more time to design, plan, ramp up their programs prior to their start. And likewise, the variation, that complexity may need to be factored in when we actually try to measure and compare those program outcomes. And likewise, since programs face a lot of the same challenges that they're intended to address, including gaps in the local mental health system, structural inequalities, other systemic barriers, there may need to be more effort put in giving those programs the tools to adequately deal with the external challenges they will face. And that may just mean more assessments of existing resources, but also opportunities to exchange information, to learn from each other, and to mitigate against areas of shared challenge. These programs also show how important adaptation, flexibility, partnerships, and leadership engagement are. it's critical to make sure that there are active communication channels within these organizations. And it may be necessary to regularly revisit terms, grant terms, and make sure that there is proper communication and goal alignment. And indeed, they may need additional forms of support in order to develop their own organizational and community partnerships to help to reduce the state burden for some of that support. Of course, we noted they benefited from additional, very experienced and dedicated staff. So identifying the signs of burnout and the stresses that are on those staff is also incredibly important, and finding ways of continually mitigating against staff loss, also critically important. Finally, there is a great need for additional sustainability understanding, including efforts towards specific sustainability plans that really identify funding sources from the start. It is very difficult while you are flying the plane, as many people say, to identify a source of funding for the plane. Once it's in the air, it may be a little difficult to do that. So hopefully we can also support additional learning opportunities and support for the communities to advocate for additional funding. So I appreciate your time. I know this is a lot of information in a short period of time, but I am going to turn this over now to Mark Saville over at UC Davis to talk about the TAE and adult program.
Okay, so good afternoon, everybody. My name, as Dr. Vanek just said, is Mark Saville, and I'm going to be presenting the main findings from the formative evaluation of the SB 82 funded TAE and adult crisis programs. And before we start, I just want to make sort of super clear that as a formative evaluation, the primary focus is on evaluating the development and implementation of these programs across the state. So we have made some early efforts to explore possible impacts of the programs qualitatively, but a more thorough evaluation of the impact is really reserved for the summative evaluation, which is being conducted by Dr. Callie Clark and her team at the Commission. So next slide. Thank you. As always, I just want to start by recognizing the amazing team that's been working on this project over the past few years, not least Dr. Sherry Melker and Dr. Cameron Carter, who have led the project. Next slide. Okay, so just for a very brief background, in 2013, the Senate Bill 82, so SB 82 was passed, and it established a competitive grant program for California counties for the purposes of developing mental health crisis support programs. And funds were allocated to increase the availability of services focused on crisis intervention, stabilization, crisis residential treatment, rehabilitative mental health services, and mobile crisis support teams. And the aims of these programs were to expand the availability of care, to improve client experience through supporting recovery and wellness, whilst also reducing costs, to reduce hospitalizations and inpatient days, and also to reduce recidivism and law enforcement expenditure. Next slide. Okay, so since the Act has passed, there has been multiple rounds of funding, and this evaluation focuses on the second round of grants, which were distributed in 2018. And in this round, 14 counties and 1 city were awarded grants for the adult and TAE services, which are indicated on this map here. And as a condition of this award, programs required to be part of this statewide evaluation. Next slide. Okay, so to conduct this evaluation, we adopted a mixed method approach, and that's included 3 rounds of qualitative interviews. So 2 with providers, so 1 in 2019, and then a more comprehensive one in 2021. And then in 2022, we also conducted qualitative interviews with service users and collaborating law enforcement partners to better understand their experiences of either collaborating with or receiving care from these programs. On the quantitative side, the main source of data has come from 2 rounds of program surveys. And these were developed in collaboration with the programs, our advisory board members, other experts in the field, and were based primarily on data extracted from program electronic medical records, so EMRs. Whilst most counties completed all the same surveys, slightly different ones were produced for LA and the city of Berkeley, given the unique nature of their programs. And then finally, we also collected some data from a host of other sources. And these include memoranda of understanding that they might have developed with community partners, county census data, original and later modified grant proposals, hiring reports, and then through various community partner engagement activities, such as webinars and program meets hosted by the OAC. Next slide. Okay, and before we get to the evaluation findings, I think it's really important to address issues concerning equity and engagement. And I think that's something that's incredibly important across behavioral health service evaluation efforts generally, but it's an area that's particularly important in crisis intervention, given the nature of these services, the disparities we see in crisis care outcomes, and also the degree to which these services interact with so many different elements of the community at large. And so in consideration of that, we really utilize a three-pronged approach. So one is in oversight, and that's really addressed through our community advisory committee. And so we had committees, members with professional or personal experience of interacting with crisis services. And this committee really has had quite a notable impact on sort of the design and the interpretation of our evaluation, and has really been an important feature to help us address any blind spots that we as a team might have. The second has been in our research approach. So some of the quantitative data we've collected is focused on exploring accessibility and treatment across demographic groups. And in the second round, again, in part from the feedback that we got from our advisory committee, we started exploring delivery of culturally responsive practices and training and availability of materials that can support that. In the qualitative work, I think it's fair to say recruitment was highly challenging generally, but we did try to recruit a representative range of participants, both in terms of socio-demographics and also the roles they undertook in terms of providers. So having very senior folks, and also really trying to recruit a number of peer advisors as well, so they can kind of bring that very different perspective across the programs. And then finally, so we've been hosting a series of public engagement efforts, just like this one. And the idea is to solicit further feedback from hopefully a diverse range of community partners. So based on that, as others have mentioned earlier, we would really welcome your feedback either during the Q&A at the end or in any follow-up correspondences that we'd be very happy to have. So next slide. Okay, so that's the summary of the context. So I'm now going to talk about some of the main evaluation findings. Next slide. And the structure of our final evaluation sort of comprised of 5 distinct areas. And these include, number one, the different program structures and contextual factors that may exist in these programs. Number two, looking at sort of what services were delivered and the populations that were served. Number three, as I mentioned, this sort of qualitative exploration of the impact of services from the perspective of community partners. And then 4 and 5 are linked together, where we looked at the barriers and facilitators to effective program delivery. Next slide. So way back in sort of beginning of 2019, the first thing we looked at was the structure of these programs. And through the interviews and the review process of all the proposals they had, whilst there was a lot of heterogeneity in service delivery, all appeared to focus on at least 1 of 4 different stages across the crisis care continuum. And these included sort of the first one, which is prevention services, where providers work with individuals identified at high risk of experiencing future crises, either based on their history of engagement with law enforcement or other behavioral health services. The next one is crisis access and lifeline services. And these are services that provide support to clients to access crisis care in times of need. And in some cases, that could overlap with prevention services, whilst a more distinct version that a number of them had were hotlines, where people can either call to receive emotional support, and if necessary, for call center personnel to arrange in-person emergency response assessments with a behavioral health provider. And that sort of links nicely to the third stage, which is mobile crisis assessment and triage. So this is mobile crisis assessment teams that engage with individuals in the field to first try to de-escalate crises, then to conduct a behavioral health assessment, and then potentially triage individuals to the appropriate level of care based on need. And then the final stage we looked at was programs that provided services to individuals who either received a crisis assessment and didn't meet criteria for hospitalization, or those that were hospitalized and then were recently discharged from hospital. And the primary aim of these services were to provide case management and facilitate linkage to ongoing recovery-oriented behavioral health services. Now, I think this is an area in particular, I think that's really interesting for a couple of reasons. So number one, as we can see from this table, is the one that really pretty much all of them focused on. So 13 of the 15 programs use some of their SB 82 dollars to provide this. And I think the second thing is that it's not been quite as part of the national conversation as some of the other areas of crisis care. So at present, sort of when we look at the conversation on the national level, the focus has really been on sort of someone to call, someone to respond, somewhere to go. However, I think it's really interesting that when counties are given funds to flexibly address what they consider to be some of the major issues in crisis care delivery, what the vast majority of the counties focused at least some of their grant dollars on was someone to provide support afterwards. And I think that's really important because it suggests an expansion of what we consider encompassing crisis care may be necessary in the broader debate. Next slide. Okay, so I've talked a little bit about the structure of the program. So now I'm going to move on to the evaluation of the services delivered in the population served. So I think the first thing to highlight, over the course of the project, 14 of the grant recipients that were surveyed reported providing over 81,000 services during 23,500 encounters with 17,400 individual clients. So this is a huge amount of additional care provision that might not otherwise have happened without the existence of these programs and the grants that supported the delivery or the expansion of these programs. So already, I think that suggests that these programs really met that first aim that I talked about at the very beginning, where we're talking about trying to expand the delivery of crisis care. I think another thing to say is it's notable that we saw an increase in that care delivery over the duration of the award as well. Next slide. Okay, so hopefully this is big enough to see. The next slide highlights the types of services delivered. And as what should hopefully be clear, so the first two really tall bars, so case management and outreach, represented by far the largest proportion of the activities that these programs reported. Some of the smaller ones, or other key pieces, was work around crisis interventions, assessment, supporting rehabilitation, and plan development. Next slide. And the final slide I'm going to focus on highlights the types of services delivered. And again, looking at the first two, so the largest two on the left-hand side, is outpatient clinic services and housing services. So what we're having, this is data where when somebody has been seen by these services, with who they are referring, where they're being referred onto. And I think that's pretty critical. That what we're seeing is it's community outpatient services. It's not ED wards. It's not more kind of restrictive care options. And given one of the primary aims of these projects is to divert people away from ED and away from psychiatric emergency beds, I think this is a really encouraging finding. I mean, obviously, we don't know what the outcomes would have been if they weren't seen by SB 82 services, so we can only speculate as to what the outcomes would have been without the presence of these programs. But the fact that this is where these people are going, having been seen by these services, I think is a very important thing to note. Next slide. Okay, so regarding the population served, across the programs we see is a fairly even split between males and females, so 53% male, 46% female. And across race and ethnicity, it's broadly representative of the counties they serve, although I think it's important to note that we do see an underrepresentation of individuals that identified as Asian or Asian American. So that was one thing that kind of did stand out a little bit, sort of thinking about how we can support members from those communities more effectively may be important going forwards. Next slide. Okay, so looking at the impact of services from the perspective of community partners and providers, we explored this qualitatively, and we collected a pretty large number of quotes from sort of personal experiences of either delivering, receiving, or collaborating with these programs. And there's a lot of information about a substantial range of outcomes. And these included people having sort of personal experiences of seeing reductions in psychiatric hospitalizations, in reductions in evictions, homelessness, and suicide, in seeing reductions in ED and law enforcement involvement in crisis care, and also seeing improved client and community level satisfaction in behavioral health crisis care. So again, this is qualitative rather than quantitative data, but this is the experience of people that are either delivering or receiving these services, what they're seeing day in, day out doing this kind of work. Next slide. And when we try to understand how crisis care can improve outcomes, 3 different potential mechanisms were identified. So first, it was crisis specialists typically had a much better knowledge of the local behavioral healthcare landscape, and linked to that kind of established positive relationships with different programs. So many providers talked about knowing what different services might be available that can best meet the client level of need, and also how to navigate entry into such programs in the most streamlined way possible. So knowing what might be out there as an alternative to an inpatient admission or an ED ward. Second, having this sort of behavioral background and this expertise in crisis assessment, a number of providers and law enforcement partners sort of looked at their own approaches and sort of saw this as an important facilitator to leading to improved relationship with the clients in crisis. And this was seen to lead to more effective de-escalation, which then in turn can open up the opportunity for less restrictive care options. Additionally, and this is particularly for clients who they saw frequently or sort of had a lot of interaction with the behavioral health system, they talked about having much more client knowledge of that individual, which was able to give much better context in the situation that they may be attending to, that led to more effective assessment and also care planning. And then I think the third thing that came up quite a lot, which I think is perhaps most interesting, is a number of these crisis providers talked about how crisis programs can foster ongoing positive relationships with individuals that are either completely disengaged or highly ambivalent about the system broadly, but behavioral health systems specifically. And for many, this was seen as a critical first step in clients becoming even receptive to thinking about their behavioral health needs and getting support from structured systems. And over time, and sometimes even over many crisis events, this was seen to change the dynamic that can exist between service users and the healthcare system, which was seen as a really key step to facilitating engagement into longer term care. Next slide. Okay, and sort of linked to that, I'm gonna just talk about one of the first ones, which was really one of the law enforcement partners we spoke to, contrasting how they approach crisis care to what they often see where they collaborate with behavioral health specialists. So if I go on a call where someone says that their family member is suicidal and they've slit their wrists, my assessment is typically this person is 5150, so requires an involuntary inpatient admission, and they would need to go to the hospital. Now, the crisis team doesn't always do that. They will give them options. And maybe it's because they have a deeper understanding of what the behaviors are causing, or they've dealt with this kind of stuff a lot more in an extensive manner, but they won't always place that person on a hold or take them to the hospital. So again, it's just showing that much more expensive expertise in this area, having a broader range of options when they're attending to a crisis situation. Next slide. Okay, so the fourth area I'm going to focus on is our exploration of barriers to effective crisis care delivery. And these sort of corresponded to three main themes, which included client level factors, program level factors, and then these kind of broader system level factors. And regarding client factors, one of the biggest barriers to effective crisis care were challenges pertaining to client motivation to engage in care. And a number of different areas were found to impact this, including symptom severity, ongoing substance use, insight, and client age, where younger clients, providers reported were typically less interested in engaging. Other concerns included homelessness, where multiple providers talked about the challenge of maintaining engagement with individuals without a fixed address, and particularly when these clients would often lose or switch phones, so having this sort of continuity of care being a real challenge. Regarding program level factors, multiple issues were identified, but by far the most consistent was regarding the challenge of hiring and retaining providers. So something very similar to what Dr. Amali was talking about with the programs that they were evaluating. Other reported barriers included the insufficient capacity of their programs, so the demand sort of really outstripping the supply, and the amount of paperwork and bureaucracy that many providers had to deal with to work in this space that they considered excessive. And then regarding system level factors, one frequently reported barrier was considered to be the lack of wider service availability. And a particular one that came up a lot was regarding housing services. Other issues included the challenges of delivering care in rural spaces, although for some that did also offer some advantages, which was quite interesting. The volume of inappropriate referrals that some programs received, particularly at the beginning, and also sort of county level policies such as mandated law enforcement co-response. So different counties having different ways in which these programs have to deliver crisis care, having a real impact in the way that they're able to deliver these services. Next slide. Okay, and so then linked to that, I have a quote here from one of the providers that gave their perspective of what it was like to be in a county where law enforcement had to attend every crisis assessment. We don't yet have a system in place for if law enforcement doesn't go out on these crisis calls. And my thoughts are about that. We should. It's not okay that law enforcement is going out in situations, in my opinion, where it's a situation that could be handled by a social worker kind of intervention. Next slide. Okay, so the final topic we explored related to facilitators to effective crisis care. And in total, we had, again, three broad aims, so three broad themes that came up. And the first one was about the provider approach to care. So approaching the work in an empathetic manner, being very aware of the power differential that can exist between the role of client and provider, where they can potentially take away their liberty. And so linked to that, the importance of rapport building, developing trust both within the assessment and on an ongoing basis. And that was something that law enforcement partners talked about an awful lot as well, about if that trust is broken, it being incredibly difficult to build that back, and that can have real ramifications both in the actual assessment itself, but also going forwards because people don't forget. Others talked about sort of follow through and integrity, so it's similar to that as well. And then the final thing that a lot of people mentioned was a focus on immediate needs. And something as simple as just having food and water in your trunk when you're doing these community assessments can really be very effective in helping sort of positively frame the assessment, having something where it's addressing sort of very basic needs, and then that's starting things off on the right foot. So the second thing we talk about is the optimal crisis service structure. And for that, sort of many participants talked extensively about being field-based. So obviously with the exception of hotlines, but meeting people where they are was seen to be critical. Another important feature was the extended hours of operation, which meant that both they are better able to serve the needs of the community, and in terms of law enforcement, be able to support them in the hours when they really felt that this was most important. So very late at night and weekends, where some of the programs weren't a 24/7 service, and when that wasn't there, the law enforcement really sort of fed back to us that that was a huge deficit that they struggled with. And then the last thing I want to talk about is the role of peers in crisis service delivery. So across the programs we spoke to, 60% had peers on staff. And with regards to peers, many providers emphasized the power and importance of being able to break down barriers to engagement, to help address some of that power balance that I mentioned, and also be able to communicate kind of real hope to service users and family members alike. And then actually, sorry, there's one more I'm going to highlight as well, which is the importance of collaborating partners to effectively deliver crisis care. And this could include relationships with local law enforcement, ED staff, other behavioral health service providers, and also the wider support service as well. And one of the reasons why they were considered so important was because they were really seen to be critical to enable pathways through crisis care. So getting the appropriate referrals into their programs, and then effective linkage onto more longer term services. And then linked to that, it was really quite notable that in a couple of situations where participants felt that their service was being massively underutilized, the lack of coordination with partners appeared to be playing a big factor in that. Next slide. Okay, so I talked a little bit earlier about the importance of peers, and I'm just going to read a quote from one of the peer specialists, sort of that I think really encapsulates how this role can be so unique and how it's important in this particular space. The peers are amazing in knowing the community partners, and not just knowing them, but having utilized these different services at one time themselves, or continue to utilize themselves, knowing exactly where to pinpoint them or take them to those services. That really makes them amazing. Next slide. Okay, so during this presentation, I was able to provide sort of a high-level summary of the findings, but hopefully it kind of gives a bit of a snapshot into what's happening with these programs, how they're being implemented, and what the impacts of them are. So across those 5 areas I've talked about, regarding program structures, we have seen substantial heterogeneity in the programs, each of them focusing on different components of the crisis care continuum. In terms of the services delivered and population served, we saw that these programs served over 80,000 services to over 17,000 clients across 2018 to 2021. And when they are seen, in most cases, service users will refer to lower intensity behavioral health services. With regards to the impact of services, providers, law enforcement partners, and clients reported that these programs are having notable positive impacts related to some of the pre-specified aims that I said at the very beginning. Next slide. And then with regards to the barriers and facilitators to effective crisis care delivery, we do see multiple barriers at the client, the program, and the system level that really need to be addressed to optimize crisis care delivery. And when we think of how to sort of facilitate this effective care delivery, sort of number one, thinking about the provider approach, how we're engaging in this type of care, the importance of developing sort of fruitful partnerships with programs being critical, sort of thinking about utilizing peers within these services, and then also using a field-based approach with the extended hours availability being critical to meet that need. Next slide. Great, so that's my presentation. Thank you so much for being here and listening, and yeah, we'll be very happy to answer any questions that the audience may have.
Oops. I gotta unmute. Thank you so much for these wonderful presentations and the overarching themes that came out of these formative evaluations. I want to in the interest of time, make sure that we are able to field any questions that the audience may have. I don't see any in the chat that we need to address. So at this time, I'd like to just open it up to our audience members. Questions or comments? Oh, thanks, Amanda. Sorry. If you do have them, please put them in the chat and then we'll be able to address them that way. And Amanda's put a prompt in to just get people thinking. So was there anything about the findings that surprised you?
Oh, I just got a question to myself, so I'll read it out and I'll make a chance to answer it. It says, how much did you guys look at the first recipients of the grant? So I have to say we haven't actually had a chance to do that. I think that would be really interesting to see for a number of reasons. So one, I think obviously both our programs, the TANET and the child and school ones, were massively impacted by COVID in the middle. So it ended up being a huge restructure and reorganization of the system. So to see how these were going when they could perhaps have been implemented more in line with how they expected them to, we may have seen very different things in terms of the outcomes and the experiences that the programs may have had. I think another thing that would be really interesting is, so it may just be a feature of me working in this space, but I think we've really seen a lot more focus over crisis intervention and crisis services over the past sort of 5 years or so. So in the 6 or so years I've been working in this space, I think it's really become quite a hot topic in this space. And I think we have much more focus on providing care to this space. And that's a huge part of California's approach to addressing some of the challenges that we have in this space, but also nationally as well. So I think understanding what it would have been like sort of at the early stages before things like 988 and before this kind of big expansion and these kind of conversations that we're having, it'd be really interesting to see how they sort of address and tackle some of these challenges. I don't know if you have any thoughts, Corey.
No, I mean, I think you mostly covered it. We did look at least on the child and school county side, for some of the programs that had received round one funding, we did look at, some of the reports that were available, but it wasn't always the same counties that were awardees. And then just the scope of our evaluation was really limited to this program. But I agree completely with Dr. Saville. It would have been a really interesting comparison to make, especially with the pandemic. So thank you.
So I have another question here. I don't know if it's gone to everyone, so again, I'll read it out. Was the lack of focus on prevention and early intervention programs due to the lack of funding or because it wasn't seen as a need? That's a fabulous question. Yes, I mean, we'll have to think about why folks chose to use the money in the way that they did. I don't know if part of it was the way in which the grants were interpreted when they were released. And if it is thinking about that sort of window of when a crisis happens as opposed to prevention, so just not thinking sort of perhaps in that way about how the different way this funding could be used. But yeah, it is surprising. I think it was only three counties of the 15 that we worked with that actually did focus more on that prevention work. And I think it's fair, the ones we did focus on sort of from the qualitative work, they saw it to be hugely impactful. So we talked to one person in particular that spent a lot of their time working with their full service partnership folks and really providing a lot of intervention and support with those. They found, I think they spoke to the ones where the highest frequency of 911 callers amongst their FSP groups and really focused and supported those ones. And then they saw really quite amazing numbers with that cohort specifically. So I think it does seem to be an area that potentially could be something that's very impactful. But it is notable that it was only a few of the programs that focus on that, as opposed to the post-crisis thing, which is what a lot of them seem to be doing.
I'll add to that on the child and the school county side that there were more of the youth programs were focused on prevention and early intervention. A lot of them had to really substantially downscale what they were doing in those areas when the pandemic started, and also as a result of some budget cuts that occurred early in the grant program. So we did notice that the prevention and early intervention, those were more or less, if there's a cut that happens, those are the first ones to go, because the feeling is as if there is also a need for acute crisis services, which tend to be more emergency life and death kinds of situations, you need to make sure that's there. And then there's this perception, however right or wrong, that prevention and early intervention is something you can focus on once you've made sure that you've addressed those acute needs. But that was actually a really common area of concern, that they had to scale back some of those components. I'm also seeing a question about formats for collaboration. I'm going to just jump on that really quick and say that we had such a small number of cases that, at least on the school county side and the child side, it's hard to say what's the most successful format for collaboration, except to say that where there is more embeddedness, where the collaboration is more direct, they're housed in the same location, it seems to produce a stronger partnership. So a lot of the difficulties with communication, leadership engagement tended to come down into cases where the collaboration was very indirect or kind of remote, as opposed to situations where the collaboration is really direct and in a particular agency where all of the leadership has kind of goal alignment. I'll pass that on.
That's interesting you say that, Corey, because I was about to say pretty much exactly the same thing. So the law enforcement providers we were talking about, I can think of two departments in particular where when they said it was incredibly successful because they had their own desk in the police department. They were seen as part of the team. They weren't someone else, they were us. And I think it had a number of ramifications in terms of the impact of that. So law enforcement providers were talking about having someone they can just informally speak to and help them understand things, that help them modify their own practices because it's someone within their team showing a different way. There was even one provider that was talking about it enabled them to think about their own behavioral health and wellness needs in a different way, to kind of break down this stigma around what it means to open up and be honest about the trauma and the experiences that you may have as a law enforcement partner working in these spaces. So I think the two I'm thinking of in particular, I think that integration was really a critical part of what made it such a success.
Do we have time to take more questions, or are we?
It is 4 o'clock. I just see one more question about was there clear data on what were the system needs versus the client treatment needs? I think we can answer that one and then wrap up for the day.
I guess I'll tackle that one first. The client treatment needs. The data that we received, I'm speaking, I guess, both for UCLA and UC Davis. We did not receive client level data. We used aggregated data in all cases. So individual client treatment needs were really not as part of a formative evaluation what our goal was, but we were really attempting to maybe identify what some of those system needs are and contrast them with treatment needs broadly, or community needs, or client needs in the broadest sense, as opposed to for individuals. If that makes sense.
And if I'm understanding you correctly, right, about the system needs, I think what came up most with all three, so clients, providers, and law enforcement partners, the thing that was really missing in the system was housing. And a number of folks talking about, yes, that person being in crisis, but there being a whole number of issues in which that person may be managing, of which this discrete event may be one of lots of different things. And to really make sort of substantive progress going forwards is addressing basic needs. So the food and water is something that can help, but that's an immediate need. The long-term immediate, like real critical need was housing. And when people didn't have homes or didn't have secure housing, that being a much really not kind of hitting the sides of what their needs are and what they need to do going forward. So housing was the real kind of thing that came up when we thought about some of the system level challenges to really making progress and supporting recovery amongst the people that they worked with.
Yeah, and co-sign with the child and the school county. We weren't able to link essentially those system level things to individuals' treatments and things like that. But broadly, yeah, I mean, I think a lot of what we were trying to do is sort of identify what are those system level problems that providers were hearing about again and again from their clients.
And of course, the summative evaluation will have some focus on those individual level outcomes. And that report, we're still in data collection. And I think the first draft of that report is scheduled to come out next spring. So we'll do our best to try to tie some of these system level issues to the individual level client needs and outcomes. Well, I really appreciate everyone coming and listening to the wonderful presentations. Thank you, Dr. O'Malley and Dr. Saville, for representing the UC Davis and UCLA teams. We have another opportunity tomorrow morning to present this information, but really appreciate everyone coming today and listening to the webinar.